Okay, here we go. Kinesiology 230. This is chapter 20. We're still talking about clients with cardiovascular respiratory conditions. This is presentation 4 out of 4 for this chapter. And this is about chronic obstructive pulmonary disease, also known as COPD. And then asthma and exercise-induced bronchial constriction. These are found on page 558 and 559. Let's go ahead and get going into this here. Okay. With COPD, it's a group of conditions that it's chronic inflammatory or inflammation of the lower respiratory area, meaning in the lungs. And if you think about this and how crucial it is, you have that's where oxygen gets loaded into the blood and where CO2 gets offloaded into the lungs to blow it off. And COPD is an inflammation in the lungs that actually limits that process. Now, it can be caused by any number of different things. It could be smoking, some kind of respiratory infection or illness, perhaps air pollutants per se. But the client will usually start off in some type of formal pulmonary or rehab facility for respiration, meaning the ability to breathe. But COPD patients, they have a process they go through and they end up being cleared from rehab, and then that's when you become involved. Now, I will say this, most of these individuals are encouraged by their doctors, incentivized to some degree by their doctors to become involved in exercise programs. Probably your people are going to be a little bit apprehensive at first because they walk around feeling like there's an elephant sitting on their chest and they can't breathe. But their doctors are usually the ones pushing them towards performing some type of exercise program. So you have to be able to be the extension of that rehabilitation process in your exercise program. So the book kind of differentiates here, excuse me, between asthma and exercise-induced bronchial constriction. So asthma is a chronic airway disease characterized by hypersensitivity to various stimuli. Could be cold air, pollen, air pollutants, tobacco smoke. I mean, it could be something as simple as like when we have wildfires out west and that smoky air is carried across the United States and it comes to our region. That could also be a trigger for asthma. With exercise-induced bronchial constriction, EIB, it's a short-term or acute narrowing of the airway, and it depends upon the type of activity. It could be the intensity activity, environmental conditions like we mentioned before in terms of dust, temperature, pollen, and it causes dyspnea, which is a difficulty or labored breathing. And it's a matter of people who come in who have asthma versus people who maybe are experiencing some type of acute bronchial type of issue. The asthmatics, these are individuals who know their condition. They probably have seen a doctor for their condition, and they already have in place a plan of attack if something were to happen. Most who are asthmatic will come in and sit down with you and state very clearly, I have asthma, and it's not the exercise-induced kind. It is something that is chronic, and I carry a rescue inhaler with me. And they'll be very aware of that situation and how to intervene, or when they start to feel that tightness in their chest, what they should be doing. The book specifically notes, though, that there should be an action plan in place for asthma participants. And it's a matter of having a process in place to be able to work with your people. And so the asthma action plan itself, the AAP as it's called, it should be implemented by or created by the healthcare provider. If your client doesn't have one, you should urge them and encourage them to be able to reach out to their physician to have a asthma action plan in place. Now, what this looks like is something like this, where you have a green, yellow, and red zone, and you can kind of take a moment just to reflect upon these and kind of look in terms of, you have the green zone, they have the ability to breathe rather freely, and then you get into the red zone where they have 50% of previously best barometer measured peak flow rate. And as you look at this, you can start to kind of compare and contrast and pick out, like, okay, your person is in the green, they're good to go, they're fine. A person who is in the red on the other opposite end of the spectrum, they have difficulty breathing, they're not getting better, they're actually getting worse. The medications that they normally use, whether it's a rescue inhaler or perhaps it's oral, are not working. And they they provide this dyspnea scale, which is kind of like an RPE for breathing. And it's a matter of, again, 0, there's no issue. 10, it's absolute. They have breathlessness. They can't breathe at all. And for your people, usually they'll go through a workout process, and perhaps if they have an episode, an asthmatic episode, they might have a rescue inhaler to try to pull them from, excuse me, like a 6 back down to a 3. But to a certain degree, it doesn't work, and then it becomes worse and worse and worse. So that's where you go through your asthma action plan, to determine where the person is. And it requires a little bit of communication. And people who have asthma will be very familiar with what is minor breathlessness versus absolute breathlessness. They will know, and they will be able to articulate that to you. But it doesn't mean you shouldn't take the initiative to have conversations with your clients who are asthmatic regarding their condition and the communication that's required to make sure you don't put them in a bad place. All right, so for chapter 20, that's it. I'm moving on to the next chapter. All right, guys.